Good afternoon. Today's lecture is a big chapter, overview of congenital heart disease. Professor Chowdhury Meshkat Ahmed sir is the right person to talk on the congenital heart disease. Rajgopal, he is from faculty from Malaysia. Welcome you to this session. And Professor Wadud sir and Rajia madam also with us. Wadud sir, please comment and start our session.
Assalamu alaikum and good afternoon, everybody. Welcome to today's session. Today, we're going to learn about congenital heart disease. In a nutshell, it's a big chapter. There are books about it. But we'll be hearing from Professor Chowdhury Meshkat Ahmed. He has dedicated his effort, energy, enthusiasm, study, and teaching, focusing on the development of echocardiographic service in this country. And we know congenital heart disease is something that's very, very echo-dependent on diagnosis, on management strategy, on defining the prognosis and everything. And we think Professor Chowdhury Meshkat Ahmed, Professor of Cardiology in University Cardiac Center, Bangladesh Sheikh Medical University, is the right person to talk about it. Ladies and gentlemen, let us hear what Professor Chowdhury has to offer to us. Meshkat Bhai, it's over to you.
Thank you very much. Am I audible?
Yes, sir.
Thank you very much for the kind introduction. And I'm so grateful to the directors of this platform for giving me the opportunity to have talk on this congenital heart disease. Congenital heart disease, next slide. Congenital heart disease is, next slide.
Should up?
Ji sir, ekটু wait করুন.
Yes.
Opening sir.
The circulatory
Slide, big screen, please.
Sir, it's big sir right now sir.
Okay, thank you. Sorry, you can proceed, sir.
The definition is very simple. When there is cardiocirculatory structural functional defect at the birth, maybe it will manifest later in their life, will be congenital heart disease, and 0.8% live birth do suffer from this congenital heart disease. Next slide. There are some specific predilection for gender for certain disease, especially atrial septal defect and conductor circulation is common with female. On the other hand, aortic heart disease and the coaptation of the aorta is common with the male. Next. There are no certain etiology, but there are some association are thought to be strongly associated with this congenital heart disease, especially the chromosomal disorder, cytogenetic disorder, the famous one, Down syndrome we know, and we also know about the Turner syndrome, trisomy 18. And there are some deletion in the arms of the chromosome, like Williams syndrome and DiGeorge syndrome. Next slide. Also, it can occur due to Mendelian disorder of the remote abdomen. Next slide. Next. Environmental factor, maternal infection, and maternal drugs and other also being associated.
একটু জোরে বলতে হবে, একটু কম শোনা যাচ্ছে.
Environmental factors are maternal infection like rubella, even the influenza viruses. They are also responsible for congenital heart disease to some extent. And not to forget about the drugs. The maternal use of alcohol, marijuana, lithium, and other things also causes congenital heart disease. Next slide. So, the objective of today's session is to facilitate how to learn this subject, because I'm not really with this subject. I'm also learning this subject. And specifically, the way I will try to utilize the session is by experience, the way I'm learning the subject. And that is what I can do. So I'll not be that organized. I'd rather request you to have some pen and few papers because the slide will not be organized in that way. So you may miss some points that you can note down. Next slide, please. So the congenital heart disease is the applied clinical logical epitome. Is a classical example is congenital heart disease. Nature has to be very perfect with its structure and its function. Otherwise, the organ will not survive. And what best organ other than heart and the circulatory system could be there to exemplify this association of structure and the function. So in my learning process of congenital heart disease, I tried to understand the basic anatomy, basic morbid anatomy, and the physiology that comes subsequent to that, and then try to integrate the whole thing into the clinical practice, anticipating what next can happen, what next investigation should I send for. And after getting all those information, then if we can answer these 5 questions, probably the congenital heart disease, which appears so difficult and so tough, especially the cyanotic congenital heart disease, may not be that difficult, and we can simplify this. Especially the first 2 questions are important, whether the patient is cyanotic or not, and then whether the patient has got increased blood flow. And if subsequently we can give answer to some of the questions in 3, 4, 5, then probably we'll be able to formulate some diagnosis. Next slide, please. So the classification has broadly been done on cyanotic and acyanotic disorder. And among the acyanotic disorder, which is rather common in our adult practice. Next slide, please. Acyanotic disorder, we know shunt anomalies and the anomalies that occurs without shunt when there is normal or decreased pulmonary arterial flow. As I said, the cyanosis is the first concern, and the second concern is the flow in the pulmonary circulation. And when it is increased, obviously the increase is due to left to right shunt and the other non-shunt disease, which can originate in the left side or on the right side. Next slide, please. Next slide, please. So starting from the right side, starting from the vena cava up to the pulmonary artery, we know the commoner diseases are atrial septal defect, ventricular septal defect, and the pulmonary patent ductus arteriosus are the shunt anomalies. But without shunt, we have the abnormality in the right ventricle, in the tricuspid valve, in the right ventricular outflow, in the pulmonary valve, and also in the pulmonary arteries. Next slide, please. So among the shunt, we know, the acyanotic disease malformation that originates in the left side, that again start from the pulmonary vein up to the thoracic aorta, pulmonary venous stenosis, and the quad triatriatum are there. The clinical picture are similar to that of mitral stenosis, but in echo you will not find mitral stenosis. And if someone has the clinical feature of mitral stenosis, especially pulmonary hypertension, and you don't get any other cause, and the left heart is also normal, then probably you have to look for the abnormality like pulmonary venous stenosis and the quad triatriatum. And other disorder, we know the disorder in the mitral and the aortic valve, and there are some subvalvular aortic subvalvular changes in the aortic valve which give hypertrophic cardiomyopathy and the supravalvular aortic stenosis. Next slide, please. Cyanotic heart disease with shunt, we are quite familiar. In atrial level, we have atrial septal defect, we have ventricular septal defect, and in the great artery level, we know we have patent ductus arteriosus. But we also have to keep in your mind to exhaust the list of acyanotic heart disease with shunt. The aortic level shunt are also important. Especially, we know rupture sinus of valsalva is not that common. that is when in aortic root there is rupture of the sinus sulci and it communicates with the right side of the heart, then it forms the left to right shunt. There are other forms of left to right shunt like aortopulmonary window, and the coronary artery is a branch of aorta which again lies at the root of the aorta, and the coronary artery can be fistulous with the coronary sinus, can have fistulous connection with the pulmonary artery, also with the right ventricle. So coronary artery can formulate another example of left to right shunt in acyanotic heart disease. We have to keep those in mind. Next slide, please. Always we are scared about talking on cyanotic congenital heart disease because we only know the tetralogy of Fallot and the Aysen-Menger syndrome, and we know so little about rest of the things. But as I said, the way I wanted to learn the congenital heart disease is by applying the structure, the anatomy, and the function. So I tried to solve this according to my own way. We have got 4 baskets. Marker na ekhane. Previous slide. Marker.
So this one.
Marker. Okay.
Sir, there is the marker one, sir. Left side.
Left side?
Yes, sir.
Which one?
It's showing slowly, sir. Color টা একটু prominent না, sir. That's why এটা দেখা যাচ্ছে না.
আচ্ছা আচ্ছা। হ্যাঁ দেখা যাচ্ছে মার্কারটা কিন্তু।
জি স্যার।
সরি কিন্তু
এই যে স্যার।
Previous slide.
জি স্যার। This one, sir.
Next slide.
This one,
okay,
sir.
This one.
So we have 4 components: the increased pulmonary arterial flow. দেখা যাচ্ছে?
দেখা যাচ্ছে স্যার।
Pulmonary hypertension with decreased flow or normal flow. Right dominant without pulmonary hypertension, and the left dominant. So the way I try to compile all these things is pulmonary hypertension, this component with dominant right ventricle. Basically, there is no primary disease fall into this basket. Either increase arterial flow, the condition that gives increased arterial flow, and the cyanosis subsequently turns into, some of them turns into pulmonary hypertension. So this basket is a secondary basket. And as regard this one, dominant left ventricle, almost all cyanotic heart disease in congenital heart disease practice are right dominant, generally speaking, but with few exceptions like pulmonary atresia with atrial septal defect, pulmonary atresia when having non-restrictive ventricular septal defect, and Ebstein anomalies, tricuspid atresia with non-restrictive ventricular septal defect. If you look at the anatomy, if you have tricuspid atresia, meaning right atrium has got no connection with right ventricle, then it has to use atrial septal defect to enter into the circulation. And if there is non-restrictive ventricular septal defect, then again the left ventricle is going to be the dominant ventricle. So So tricuspid atresia is one of the examples when there is also we have non-restricted ventricular septal defect. But if we have, sorry, restricted ventricular septal defect. But if we have non-restricted ventricular septal defect, then again the blood will go to the right side of the heart and it will produce an example of increased pulmonary artery flow of cyanosis. So tricuspid atresia, when has got non-restricted ventricular septal defect, it produces the example of this increased arterial flow. But when there is non-restricted VSD, tricuspid atresia, atrial septal defect, non-restrictive ventricular septal defect, then the left side is going to be dominant. So in this basket, we have only 2 or 3 diseases. Tricuspid atresia, which is rather rare, with restricted VSD. We have Ebstein anomalies, and we have pulmonary atresia with atrial septal defect. Because in pulmonary valve atresia, the right ventricle will be mere approach. So all the blood will go to the left ventricle through the atrial septal defect. So 3 conditions. So we are done with this one. We are done with this one. And if we give attention to this part, that is normal or decreased pulmonary arterial flow with dominant right ventricular, any obstruction in the pulmonary outflow tract, that is valvular or subvalvular pulmonary stenosis without atresia, that will eventually give rise increased pressure in the right ventricle. And even if there is non-restrictive VSD, the right ventricle will share the pressure of the left ventricle. And those will be the example of this basket. So dominant right ventricle, pulmonary hypertension is absent. The logical sequence of the obstruction in the outflow tract, like pulmonary stenosis, will be the only example. And the condition that causes pulmonary stenosis, like pulmonary stenosis itself, and the pulmonary stenosis with non-restricted VSD. And in many patients, which also come from this group, when they have pulmonary stenosis, like transposition of the great vessel and like totally anomalous pulmonary venous drainage or double outlet right ventricle, then from this basket, some will fall into this basket. So we have pulmonary hypertension, no primary disease is there. We have dominant left ventricle with normal or decreased pulmonary artery pressure. We have tricuspid atresia and the pulmonary valve atresia. And in this group, we have got the group of patients which has got pulmonary stenosis, either pure pulmonary stenosis or pulmonary stenosis associated with some increased pulmonary arterial flow condition like transposition of the great vessel or double outlet right ventricle. Next slide, please. So now we turn to the main bag. That is the increased pulmonary arterial blood flow component. In transposition of the great vessel, the TGA, and in Tacit Bing anomaly, this is actually the double right ventricular outflow tract condition, truncus arteriosus. In all these conditions, when we have non-restricted ventricular septal defect, and there is obstruction somewhere, then we'll get more blood into the pulmonary circulation. This is one of the mechanisms. The second mechanism is when the pulmonary circulation is directly communicated with the left ventricle, the high pressure sink. So in complete transposition of the great arteries, we have pulmonary artery arising from the left ventricle, and also in truncus arteriosus, the pulmonary artery get burden from the left ventricle, common aorta. So these are the conditions that ought to give increased pulmonary circulation. But in some situation when there is overriding of the aorta, and this overriding causes less blood to flow into the aorta from the left ventricle, causes more diversion of blood into the pulmonary circulation. These are the conditions like double outlet right ventricle, will get more pulmonary circulation. Will obviously get more pulmonary circulation when there is total anomalous pulmonary venous constriction, univentricular heart, common atrium. We know all this situation will give rise increase pulmonary circulation. And from this basket, complete transposition and the double outlet right ventricle will eventually, some of them will develop pulmonary hypertension and they will fall in that category. Next slide. So we talked about this tricuspid atresia, pulmonary atresia, and Epstein anomaly, dominant left ventricular with normal or decreased pulmonary flow. Next slide. Dominant right ventricle, we say, with cyanotic heart disease, pulmonary stenosis with Fallot septology, pulmonary stenosis with intact ventricular septum, and pulmonary stenosis in DORV and T. Next slide.
Okay, sir.
Shona jaচ্ছে?
Yes, sir.
Next slide. Normal. Next slide. We also have got a small when there is normal ventricle and there is a shunt like pulmonary artery venosus. Next.
Is it okay, sir?
Okay. Next slide.
Okay, sir.
দাগগুলো কি মুছা যাবে না? Next slide.
Sir.
অনেকগুলো দাগ পড়ছে, এগুলো কি প্লিজ erase the marks?
স্যার এটা স্যার মেবি স্লাইডের একটা প্রবলেম হচ্ছে স্যার।
না মার্কিং করার জন্য হচ্ছে, ওভার মার্কিং এর জন্য করা হচ্ছে। ও ইরেজার আছে, ইরেজারটা ব্যবহার করেন সে সৌরভ।
জি স্যার।
ইরেজার দিয়ে ইরেজ করে দিন।
ইরেজ করে দিন
স্যার। আমি
তো নিকে কনজেনিটাল
স্যার আমি পিডিএফ ওপেন করি স্যার একটু স্যার। PDF 1 minute sir.
1 minute.
So in understanding the congenital heart disease, the first thing we know about the anatomy, and the ancestor of the anatomy is the embryology. So we need to have little knowledge about the embryology of heart, which will give us the understanding, the morbid anatomical understanding of the congenital heart disease. In British Museum, Medical Museum,
sir, Meshkat sir, this slide is okay?
না কিন্তু দাগ আছে আপনাদের এখানে, দাগ দেখা যাচ্ছে।
এটা স্যার একটু মেবি আমার পিসি সমস্যা স্যার। সরি ফর দ্য ইন্টারাপশন স্যার।
আনডু করলে কি হবে
স্যার? আমি আমার ল্যাপটপের সমস্যা করছে স্যার এটা স্যার। মেবি সামহার এটা প্রবলেম হয়ে গেছে স্যার। আমি স্যার
ওখানে ইরেজার আছে,
স্যার স্ক্রিন শেয়ারটা অফ করে স্যার আবার একটু অন করছি স্যার, একটু সময় দেন।
ঠিক আছে, এক মিনিট
স্যার বলতে থাকেন স্যার, আপনি বলেন স্যার।
না
Meshkat sir, you can discuss about this.
So embryologically my interest is on the development of intratracheal septum, on ventricular septum, and on the development of the partition between the aorta and the pulmonary artery.
Sir, sorry for the interruption, sir. I think it's okay, sir.
It's okay. It's okay.
It's okay, sir. Sir, Meshkat sir, can you guide me where to start the slide?
You can proceed. Okay.
Right.
Go forward.
Okay.
Forward.
Forward,
okay.
Sir.
Forward,
sir.
Forward.
Sir,
you have advanced too much. Go back.
Okay, sir.
Go back.
Go back.
Yes, sir.
This
next.
Go back. Don't go too much. Slow. Go slow.
Okay, sir. This one, sir.
Forward.
Next.
Next.
You go rapid.
This one,
so
sir.
Anatomy, there I look during the development from the top one developed the great vessel, the second one, this from the top, the second one is for the right ventricle and the left ventricular outflow tract, the primitive ventricle and the primitive atrium, and the last portion is sinus venosus. And this sinus venosus portion is interesting to me because the part of this sinus venosus is incorporated into the smoother part of the right atrium, and also the coronary sinus is from this sinus venosus portion. Next slide. Next slide, please. So these are the some list of from where the adult structure developed from embryological dilatation. Next slide, please. Next, please. I'm little interested on this slide because on the right side you can see the lighter portion is the right ventricle. When the right ventricle is to the right of the left ventricle, that is, right ventricle is the ventricle. Right ventricle is the ventricle that receives blood from the inferior and the superior vena cava through right atrium. When it lies right to the left ventricle, we call it D loop. This is, we should not confuse this with dextrocardia. And when the inflow, inflow of superior and inferior vena cava through right atrium goes into that ventricle which lies left to the left ventricle, we call it L position. This is relevant when we talk about corrected transposition of the great vessel. But when there is dextrocardia, as a whole, the whole heart is moved to the left. So the D loop and the L loop will be applied in most of the cases when the heart remains at its own position, that is situs solitus. Next slide, please. I'm interested in this slide, especially if you can see the foramina for coronary sinus, because in atrial septal defect, this defect occurs just at the roof of this coronary sinus, opening of the roof of this coronary sinus, and at a time also the roof of the coronary sinus, when it is traversing through the left atrium, it becomes unroofed. And that is the situation, that is the atrial septal defect of coronary sinus variation can give rise cyanosis. This is one of the examples why patient with atrial septal defect without Eisenmenger can have transient cyanosis. So next slide, please. This is the cartoon for development of ventricular septal defect. This is again is interesting for me because the ventricular septum defect, developed from 5 places: from the muscular part, from the ventricular ingrowth itself, the left and right bulbar ridges, and from the endocardial cushion, that is from where the valve develops. So if there is defect in the endocardial cushion, there will be defect in the valve as well as in the septum. And if there is defect in the valvular ridge or in the aortopulmonary component, which also contribute to the intraventricular septum, then they give rise to infundibular or subarterial ventricular septal defect. Next slide, please. I'm also interested in this slide because it gives me the idea how, when the aorta was initially on the right, then it goes to the left, and on its course, it goes underneath the pulmonary circulation. So when we use the imaging modalities to look at the ventricular septal defect, the right plane should be at the twisting point. Just below the twisting point, we can traverse our imaging plane, be it echocardiography or be it angiography. Then we'll be able to visualize the whole spectrum of ventricular septal defect that occurs. It will start from 11 o'clock, it will be membranous VSD. At 1 o'clock, it will be subpulmonary VSD. And in 4 o'clock, it will be inlet type of ventricular septal defect. So this embryological anatomy gives me idea about how to image the ventricular septal defect, which is very much required for the surgeon. Next slide, please. So also important is fetal circulation. We have 3 shunt, especially, next slide, please. The three shunt, of which the first one, when the blood is shunted from the umbilical vein bypassing the liver. Next. The second shunt, also the pulmonary portal vein, that also bypasses. Third. Next. Next, please. And the third shunt is very important because this is the ductus arteriosus, which connects the pulmonary and systemic circulation. So in postnatal changes, the ductus obliterates. The initially blood was flowing from the inferior vena cava, and it directly enters into the left atrium and the left ventricle. So the majority of the circulation actually from placenta, which gets the oxygenated blood from the placenta, diverted through the ductus into the descending aorta. On the other hand, the blood from the inferior vena cava, it again directly enters into the left ventricle, left atrium, and then subsequently to left ventricle and the aorta. And only a few amount of blood that comes directly to the right, to the superior vena cava into the right atrium goes into the pulmonary circulation. And after birth, the whole things are changed. These major shunts are obliterated. The shunt between the great vessel and the atrium obliterated, and the pulmonary vessel itself dilated. And these are the changes that occur postnatally. Next slide, please. It gives me the previous one. It gives me the impression why patient, when ductus remain, it becomes a load to the left ventricle, because all the blood that comes from the aorta enters into the pulmonary circulation, and the actual subsequently the left side of the heart is loaded. On the other hand, the condition when there is hypoplastic left ventricle, maybe aortic atresia of the aortic valve, how this patient survives up to the neonate, because the blood is circulating through the patent ductus arteriosus. So we get so many congenital abnormalities, which apparently it seems that would not have survived the patient before their birth in the uterus. But because of this unique circulation during the fetal life, these rare cyanotic congenital heart disease do survive up to the pregnancy. And if those patients do have some auxiliary connection and auxiliary circulation from the aorta by major aortopulmonary circulation, collateral circulation, then possibly they will survive for a few years. So history is important in congenital heart disease, because it is a little bit different when the pediatrician take the history than we adult people. Development and the weight gain are important for them. Feeding difficulty is also important for them. They also encounter the tachypnea in a different way. And for adult practice, next slide, please. And for them, the neurological feature is also important, because many of the syncope are associated with neurological features. These are the symptoms that we know occurs in the adult practice. Cyanosis is very important for congenital heart disease. As we know, a big group, although their number are relatively less in adult practice, are the patients who do have cyanosis. Chest pain, we know when there is ventricular hypertrophy, and beside ventricular hypertrophy, we have mitral valve collapse and hypertrophic cardiomyopathy as a cause for chest pain. And in some patients with aortic regurgitation, we have Venturi effect. That is when the regurgitant blood goes back from the aorta to the left ventricle, it also sucks blood from the coronary artery and gives rise to pain. It's a rare form of where the chest pain is produced with valvular heart disease. Shortness of breath, we have to really clarify, because exertional shortness of breath will imply the cause probably is reduced cardiac output, that is chronic heart failure. Maybe this can be due to obstruction in the left ventricle or in the right ventricle or in the pulmonary circulation. Syncope has got two components. Syncope can be due to mechanical obstruction in left ventricular inflow, outflow, or right ventricular inflow, outflow, or pulmonary circulation. And also this can be done due to some arrhythmia, which is prevalent among patients with congenital heart disease. Palpitation, as usual, when the patient will have arrhythmia, will have palpitation. But other than that, if the patient also have left ventricular volume overload, that will also give them the palpitation. So analyzing the symptoms some way, we can reach to the structure, what probable cause could be there. Among the less important symptom, hemoptysis is important because there are many ways hemoptysis can be produced in congenital heart disease. We know acute heart failure can occur when there will be leakage of the RBC in the pulmonary alveoli. Pulmonary vein can rupture due to pressure in the right atrium due to some congenital defect in the left atrium, like pulmonary venous stenosis or quadriatriatum. There can be increased pulmonary hypertension that can produce rupture of the capillary. Important aspect of hemoptysis is rupture of the collateral circulation. For example, if a patient with tetralogy of Fallot present to you with hemoptysis, frank hemoptysis, we have to point out to the collaterals in those patients with tetralogy of Fallot. Because if you want to repair that tetralogy of Fallot, you first have to secure the collaterals. And hemoptysis also can occur from anticoagulant, from right ventricular thromboembolism and other causes. So hemoptysis is important. Next slide, please. History of cyanosis is important, whether it occurs very early, whether it occurs few months later, and whether it occurs late in their adult life. These are actually the chart which gives you some idea about which are the disease which produce early onset of the cyanosis and which produce the late onset. Actually, when the patient survive till their neonate life, and if they have collateral circulation, that collateral circulation compensate the cyanosis, and that keeps them alive for a few months. And especially there is patent ductus arteriosus is there, which may remain patent for some month or some weeks. So the patient survive and the cyanosis disappear to some extent to reappear again when the duct is closed. Or even if the duct is intact, there will be increased burden in the left side of the heart that will give rise to heart failure. So many of these patients will survive will not survive up to the first year of life. But the cyanosis will have different course, some will have cyanosis from the birth, which will disappear later, and then again reappear. And then again, this reappearance will be due to closed duct or due to left ventricular failure. In any case, they will be cyanosed and they will succumb to death. Next slide, please. Also, next slide, please. This is also, there is an important subset of cyanosis we know as paroxysmal hypoxic spell, because we are more familiar with tetralogy of Fallot. It occurs with tetralogy of Fallot, and any pathology that is similar to tetralogy of Fallot will give this paroxysmal hypoxic spell. And many a time your examiner will want to know about the features. They occur mostly in the morning after good sleep, precipitated by feeding and other things. And hypercapnia increases cyanosis depends and may develop convulsion and other things. So the mechanism is infundibular pulmonary spasm. The common question is asked why it occurs after awakening from the sleep. The answer was probably the reset of the respiratory center. Next slide, please. So there are some exertional symptoms, and you can see the list where the exertional angina or exertional syncope, if they are there, what should be there in your mind. Next slide, please. Antenatal history is important. Maternal infection like rubella, the influenza virus, maybe who knows, COVID, are important. Some drugs. Next slide, please. Some family history, as we know, it is autosomal dominant and recessive disorder to some extent. The family of consanguinity will be important. Among the drug, metronidazole, ibuprofen are the common drug that we use, can give us congenital heart disease. Although we talk about thalidomide, which is rarely used nowadays. Lithium is the other drug. Next slide, please. Next slide, please. So during examination, general examination, the patient's physical Physical appearance will be important because many of the genetic disorders are associated with other physical association. And of course, the presence of cyanosis, central, peripheral, and the differential cyanosis will be important. Next slide, please. This is typical of a cyanotic spell. Next slide, please. Next slide, please. And these are the picture how the patient get rid of their cyanotic spell. They adopt different mechanism, squatting and other mechanism. This is how they relieve their cyanotic spell. Next slide, please. So important also to look at the lip, mucous membrane, teeth, mouth, and other to find out the different syndrome that occurs with congenital heart disease. Next slide. Next, please. Next, please. So we have to look at the cyanosis and clubbing and the lips and the tongue. Next. Next slide, please. This is an example of differential cyanosis when the duct is open and there are cyanotic heart disease, and there is no entry of blood from the left ventricle to the aorta. Then all those situations give rise to this condition, differential cyanosis, when you have cyanosis in the upper limb but not in the lower one. Next. Next, please. So this is an example of congenital anomalies we commonly encounter during our practice is Holt-Oram syndrome. I'll not go into detail, but look at the dissimilarity between the length of the hand and length of the thumb. Thumb is small, hand is small. Next. This is autosomal dominant disorder associated with ASD. This is Down syndrome. You are quite familiar. Down syndrome is associated with AV canal defect, that is shunt anomalies along with some problem in the AV valve. Next. Noonan syndrome. I have picked up these cases because some of them are really easy to remember, memorize. And when you will encounter some of the rare disease later in your life, then physical appearance will instantly give you some impression what disease this patient could have. For example, this is Noonan syndrome. There is no abnormality in the chromosomes. You look at the waving of the neck. When Noonan syndrome have waving in the neck, it has got 10 times more likely to have the pulmonary stenosis, that is dysplastic pulmonary valve, not the normal pliable pulmonary valve. So these appearances give you impression about the morphogenesis, about morphological picture of the pulmonary valve, which you can anticipate. And as you see, the prominent furrow. And you also can see in the right picture the low set ear. Next, please. Next, please. And the low set hair. Next, please. This is Turner syndrome, the female counterpart, but there is their chromosomal abnormality 45XO. Turner is associated with coarctation of aorta, but not Noonan's. Next. This is PATAU syndrome, and probably chromosomal 18 also has got similar picture, clenching of the hand with some laxity in the skin. Trisomy 18 and trisomy 13, they are usually associated with ventricular septal defect. Next. I'm showing all this thing because it's relatively easier to remember. This is rather rare anomalies associated with congenital heart disease. Is pulmonary arteriovenous fistula, which is also difficult to diagnose. And this patient survived almost normal life to some extent. But an important clue that the patient might have pulmonary arteriovenous fistula is hereditary hemorrhagic telangiectasia. Next slide, please. So Ellis-Creveld syndrome, this is again associated with axial septal defect. I'm showing this picture because you look at the nail, hypoplastic nail. How does it look? And if you see this hypoplastic nail, instantly you can make a suspicion about Ellis-Creveld syndrome and subsequently to axial septal defect. Next slide, please. And again, hypoplastic nail with polydactyly from same patient. Next. DiGeorge syndrome, although this is associated with truncus arteriosus, There's deletion of the long arm of 22 chromosome. And particularly in this patient, you look at the mouth, nose. Small mouth, the nose is deformed. Palate, there can be palate cleft in the upper lip, and there is also anti-mongoloid slant in the eye. Just if you can confine your whole attention into the nose and the mouth, probably you can make a diagnosis, because this is the condition is associated with truncus arteriosus. Some of the patients with truncus arteriosus may survive up to the adulthood to meet you, and in that case, you should not miss the diagnosis if you can remember this face. Next, please. This is Williams syndrome, supravalvular aortic stenosis and supravalvular pulmonary stenosis. That is pulmonary stenosis that occurs into the pulmonary arteries. Both the condition is associated with this Williams syndrome, which is again a deletion of the 7th chromosome. The patulous lip, the puffy cheek, the big forehead, and the upturned nose. This typical of some comic picture can give you suspicion about the Williams syndrome, presence of Williams syndrome. Next slide, please. So, as usual, the past JVP and VP will be examined. Next, please. Next, please. In examining the pulse, important part is to detect the delay between the radial and femoral. And also we should check for the pulse in the other hand, because in some surgical condition, especially after surgical correction of coarctation of the aorta and some BT shunt, the left brachial pulse or the right brachial pulse may be absent. So these two special attention should be given on to this part. Next slide, please. And I'll request next slide, please. I think this should be a better method of assessing the radiofemoral delay. You see, you have to cross the patient hand on your hand that is examining the femoral pulse. So it will make you a lot accuracy in detecting the radiofemoral delay that occurs in coarctation of the aorta. Next slide, please. And also never forget to examine both the brachial arteries simultaneously. As I said, some of the conditions in congenital heart disease after surgery may have different pulse and different meaning. Next slide, please. Next slide, please. Next slide, please.
This one, sir.
Next slide, please. As usual, the same expression that applies to adult cases. Next slide, please. Next, please. Jugular vein, we know these are the general principle, these information that we get from jugular vein that we know. But in congenital heart disease, next slide, please. Next slide, please. So in top, inconspicuous, but if the patient is hypertensive and have got some complication in later life, in post-operative period especially, the A wave can be prominent. We also have A wave prominent in tricuspid atresia and in pulmonary stenosis, we know. And the famous Ebstein anomaly, which gives rise the giant A wave. And of course, when a patient do have pulmonary hypertension without ventricular septal defect, ought to give rise prominent A wave. V waves are prominent when we have got tricuspid regurgitation. Next slide, please. Next slide, please. So examination of the thorax, you look at the pericardial bulge, number 1, and you also look at the number 4, the Harrison group. These are common to all forms of congenital heart disease. If the patient has got left ventricular volume overload from very beginning of their life, is ought to have some deformity, some bulging in the left side of the heart. And if they do also have frequent respiratory infection and other things, then Harrison group develops. Other than that, certain genetic abnormalities are associated with certain features like pectus excavatum, craniatum, and the female hypoxia. Next slide, please. So let us have a little break. This is not question for you, but question also for me. Whether left parasternal lift can be better perceived during inspiration. We know all the finding in the right side is better perceived when there is inspiration. So parasternal lift should be prominent during inspiration. But the fact is, during inspiration, the heart goes away from the chest wall. So the best way to perceive the parasternal lift is at the end expiration. And if you want to palpate the right ventricle from the subxiphoid area, then you should use deep inspiration, and you can feel the right ventricle by the thumb. Next question is opening snap and the ejection click. Previous one, opening snap and the ejection click when present, are they palpable? And third question is whether audible third and fourth heart sound are also palpable. As a matter of fact, during palpation, all sort of sounds and all sorts of murmur that is more than 3/6 in grade should be palpable. We should be able to palpate all form of heart sound. And you'll not believe how easily the opening snap and ejection clicks are palpable. And so is the fourth heart sound if you really look at those. So during palpation, please give your attention thoroughly on palpation, because palpation can lead you to anticipate what you're going to get during auscultation. And as a student, you face the short case and long cases. These are really helpful. The great vessel are palpable, especially the pulmonary artery. When we have pulsation in the second left intercostal space, we call it palpable second heart sound. But we often forget that there can be also palpable pulmonary artery as well, especially when you're dealing with a case of atrial septal defect. Then you may get palpable second heart sound due to pulmonary hypertension, and at the same time you will get more laterally a palpable pulmonary artery. So everything is palpable. We look for palpation everywhere. And my last question is, we know what is the palpatory features of left ventricular pressure overload. We know this is forceful apex. We know left ventricular volume overload gives also forceful apex, but less sustained than the pressure overload. We know left parasternal lift is a feature of right ventricular pressure overload. But can we predict right ventricular volume overload that occurs in ASD and in certain conditions like total anomalous pulmonary venous drainage, whether the right ventricular volume overload can be detected on palpation? The answer is yes. If you put your three finger in the third, fourth, and the fifth intercostal space just lateral to the sternum, and you feel a gentle palpation. In patients with atrial septal defect, if you have this gentle palpation, and if you have got wide splitting of the second heart sound, then probably with clinical examination, you can sure that this patient is a candidate for surgery or intervention. You really need not to look at other picture, whether there is increased pulmonary vascular resistance or not. A mid-diastolic murmur in the tricuspid region, a wide fixed second heart sound, and the pulsation along the left sternal border will give you an estimation about the flow from the left side to the right side. That is indirect assessment of QP ratio. So we should look at this carefully. Next slide, please. Next slide, please. We have also question regarding the thrill. Most often you get murmur and a thrill in the suprasternal space, and when you are asked about the differential diagnosis, definitely aortic stenosis is the diagnosis, but what differential diagnoses are there? Then you say hypertrophic cardiomyopathy. And you have found a murmur and a thrill in the supravalvular, suprasternal space, but you are making a differential diagnosis if it is your short case, hypertrophic cardiomyopathy and other things that should not be proper. The proper answer will be if the condition that also rises the thrill in that area. Does pulmonary valve stenosis give thrill in supravalvular suprasternal space? The answer is no, because pulmonary valve restrict the flow, and maximum up to the root of the left pulmonary artery gets this burn. So there is radiation in the left side, but not up to the suprasternal space. But some patients with coarctation of the aorta do have this trill in the suprasternal space. And more surprisingly, patient with ventricular septal defect, which you often make a differential diagnosis, if it is supracrystal type, this can give rise to trill in the suprasternal space. In supracrystal type of ventricular septal defect, you get murmur intensity maximum in the second and maybe in the first stage, but at times you may get the trill in the suprasternal space. And even more surprisingly, there are some innocent murmur which can be of grade 6/6 to give systolic murmur in the suprasternal space. I will spend little time on the clinical examination because this part is less spoken. You have seminar and conferences on echo and the intervention and other things, but the clinical things are a little bit. So I'll try to share how I look at my patient and how I try to deduce all these calculations from clinical examination. So these are few points that to be noted. Next slide, please. So this is a photograph. The lower part is Bangladesh, Panchagor, Bangladesh, and the upper part is Kanchenjunga from the Nepal. I want to dedicate this picture for Dr. Virat, who answered in previous quiz so smartly, and also in memory with our tie with Nepal. We had Ravi Mala, Arun Maski, Hirachan, and we had Arun Sayami, and we had some brilliant students like Anand Khannal, Prashant, and Sabindra. We are remembering them. Next slide, please. So my third question is regarding the fixed splitting. But before that, when we have crossed the palpation and we have entered into the part of auscultation, we should always concentrate on the heart sound rather than on murmur. The first heart sound can be loud due to increased flow through the tricuspid valve, can be increased flow through the mitral valve. Increased flow through the mitral valve occurs if there is moderate size of patent ductus arteriosus or VSD, which causes shunt to go back again to the left atrium and the increased amount of blood flow through the mitral valve and give rise to loud first heart sound, mitral component of the first heart sound. But also there can be loud tricuspid component of the first heart sound due to increased flow through the tricuspid valve, which can occur in a condition like atrial septal defect and TAPVD. So next is second heart sound, and the most popular way in the examination we hear the fixed splitting of the second heart sound. Is it only ASD that gives the splitting of the second heart sound? How is about PAPVD, and how is about complete RBVD? No, PAPVD do not give rise to the fixed splitting. So is RBVD, because in ASD there is compensation from left to right when there is increased venous return. That does not occur in PAPVD or in RBVD. But when you have right heart failure, then the heart has reached at its maximum effort. And in both conditions, it cannot be expand further during inspiration. So pulmonary stenosis with right heart failure and mitral regurgitation with right heart failure ought to give the fixed splitting of the second heart sound. So if you get a murmur and a splitting at the base of the heart, and if you are during auscultation in short case, and if you are asked to say the differential diagnosis, you can be confident about saying that pulmonary stenosis, so that you can explain why there should be also fixed splitting of the second heart sound. In mitral regurgitation, if it is due to mitral valve collapse, the murmur ought to be in the left sternal A, and in that case also, if the patient also have right heart failure, is ought to give this splitting of the second heart sound. So this question was modulated for this. Next slide, please. Next slide, please. So this picture is for Dr. Hassan. He has prepared all this slide. He's having very difficult time with COVID and COVID duty and his residency program. I wish him to survive all this difficult time and save all of his love to sit that place sometime. Next slide, please. Next slide, please. So there are some pediatric practice when you have absent P wave, when you have inaudible P2. And naturally, when you have pulmonary atresia, the P2 will be absent. In truncus arteriosus, you don't have pulmonary artery to originate in the right ventricle. So how you'll get the second pulmonary component of the second heart sound. Inaudible P2 can be also in patient with transposition of the great vessel. If the great pulmonary artery lies behind aorta or it is displaced, then naturally it will be inaudible. And similar thing occurs with inaudible second heart sound. Next slide, please. So more with heart sound, you please look at the bottom part. When cyanosis is mild and great arteries are normally related, P2 ought to be soft. Maybe, but it may be preserved in tetralogy of Fallot, but a preserved P2, whatever may be the degree of cyanosis, exclude truncus arteriosus and few other diseases. Next slide, please. So we come to the next question number 4, which is again on splitting of the second heart sound. At a times you in patient you have make a diagnosis of ASD, but you cannot find the second heart sound is splitting, and you are asked to say the differential diagnosis. You make some differential diagnosis like pulmonary stenosis and other things. And then you are asked if it is pulmonary stenosis or VSD, whatever, then where is the splitting of the second heart sound? Then there can be absence of splitting of the second heart sound in patient with ASD. What are those conditions? A, when QPQS is less than 1.5 gas, blood may not be sufficient enough to produce the splitting. B, after surgical or interventional closure, yes, of course, there will be lack of splitting. When right bundle branch block is also associated with atrial septal defect, no, this is the condition not going to abolish the fixed splitting of the second heart sound. But when patient develop pulmonary hypertension and when the patient develop atrial fibrillation or sinus arrhythmia, then due to arrhythmia, you will not be able to perceive this fixed splitting of the second heart sound. And of course, there is also fixed splitting sound we found in case of TAPVD. Next slide, please. This picture is from Sylhet, the hometown of Dr. Khalid Mohsin. So this picture is dedicated to this iconic cardiologist of the country, Dr. Khalid Mohsin, who is so lovable person. He gave a good answer to your question in the previous presentation. This is Laochora National Garden, Sylhet. Next slide, please. On auscultation. On auscultation, we have to be in patient who has undergone surgery. We have to keep something in the mind, especially when there is switch operation, the aorta remains anteriorly, and we have to get loud heart sound. Aortic component of the second heart sound should be loud. Next, please. Similar way, when there is conduit in the pulmonary artery, the pulmonary component of the second heart sound will be loud. These are the things to be taken care when you are auscultating a patient who has undergone surgery. Next slide, please. Next slide, please. Next slide. These are the common things, but different multiple murmur can be there in congenital patient with congenital heart disease, and these murmurs are widely placed. You have to look very carefully in the anterior part, other part of the chest, in the lateral chest, in the posterior wall, and everywhere you have to look for murmur when you are auscultating a patient who is suspected to have congenital heart disease. Next slide, please. Continuous murmur, which is rather quite prevalent in the younger patient with congenital heart disease, and it is widespread all over the chest. Next slide, please. So these are the diastolic murmur that occurs with cyanotic heart disease. cyanotic congenital heart disease. It is important to remember this condition, especially the tetralogy of Fallot, when we can have both aortic regurgitation and in some rare cases the pulmonary regurgitation as well. And in some patients who have developed Eisenmenger syndrome may have early diastolic murmur known as Graham-Steele murmur. Almost always truncal valve has some form of regurgitation. So these are the example of diastolic murmur in cyanotic heart disease, and then we know the causes of early diastolic murmur in acyanotic heart disease, aortic regurgitation, pulmonary regurgitation, and there are host of causes of mid diastolic murmur. And for congenital heart disease, as we said, there is no mitral stenosis. There is parachute mitral stenosis, which is rather rare. We do not encounter, but there is increased flow through mitral valve due to moderate size or large size of PDA or mitral regurgitation, which can give the flow murmur, mid diastolic murmur. Also, if you have shunt, large shunt, we call it MEPCA, major aortic pulmonary collateral circulation, that occurs with so many congenital heart disease. And the shunt is really big shunt that goes into the left atrium. And then again, there is increased flow through the mitral valve. And all those shunt will give mid diastolic murmur. And there are other mid diastolic murmur due to valvulitis, rheumatic fever, Austin plate murmur, cor triatriatum, ring around pericardial constrictive ring around the mitral valve, and lot of causes are there. On the right side, you have got flow murmur for tricuspid flow in ASD, and also you have got tricuspid stenosis in some cases, which will give you mid diastolic murmur. So you can Google and you can find out the causes, but I'm trying to locate you the mechanism how these mid diastolic murmurs are formed, and especially the flow murmur in the left side of the heart, especially in relation to cyanotic heart disease, when there is increased flow due to shunt and PDA and AP window and other things, will give you mid diastolic murmur. Next slide, please. I'll take more time in clinical side. If I cannot complete my time, I will end up in the clinical part. So there are to and fro murmur. You call it as differential diagnosis of continuous murmur, which is not really good, because there is difference between to and fro murmur and the continuous murmur. Continuous murmur go through the second heart sound. Yes, it is as simple as that. But in to and fro murmur, second heart sound is very distinct. It differentiates between the systolic and the diastolic murmur, which does not occur in continuous murmur. The second heart sound is virtually merged within the second heart, within the continuous murmur. That is how you should differentiate. And these are the causes of to and fro murmur. Next slide, please. So continuous murmur, you see, we prefer to remember this in pair. Venous hum and mammary shuffle, these are the physiological condition. PDA and AP window, this is communication between the aorta and the pulmonary artery. We have collateral in the coarctation of the aorta, which gives continuous murmur, and also in peripheral pulmonary artery stenosis, we have at the times continuous murmur. And in similar way, many anomalous coronary vessel, major aortic pulmonary collaterals, and especially after shunt, the VT shunt and the port shunt. You better remember in pair all these causes for continuous murmur, and don't forget about the rupture of sinus and sinus of Valsalva as another cause. There may be some more causes like truncus and other things. You again can Google all these causes. Next slide, please. Next slide, please. So my fifth question is, in young adult, there are many innocent murmur. I'll come to that point later on, but we also have to keep in our mind the possibility about the innocent murmur. In pediatric practice especially, absence of murmur do not indicate absence of heart disease, and presence of murmur do not indicate presence of heart disease is a dictum. And how is about those murmur? Are they they are diastolic, they are continuous, they are systolic, and their intensity less than 4.6. They are systolic and continuous, but never diastolic. Has intensity more than 4/6 in some cases. As I said, there is trill in suprasternal space due to some innocent murmur that is due to brachiocephalic kinking and other things that occurs in young adult can give rise a murmur which is of grade 5/6. So the C is not true. Often radiates towards neck. Yes, of course, we know axilla, back, and elbow. Actually, the patient with supravalvular aortic stenosis show radiation to the elbow, but not this innocent murmur. But innocent murmur can be heard over the cranium and even up to 10 years of life. Relatively softer murmur, but can be heard over the cranium. Next slide, please. So a rainy day in Nepal, rainy day in Dhaka, and I was abandoned in the bottom and was stuck by the rain when very kind effort of Professor Wadud and Dr. Mohsin lifted me to the balcony of this academic area. I'm grateful to you for giving the opportunity. Thank you, sir. Next slide, please. So this is what continuous murmur you see. It really merges the second heart sound and peaks at the second heart sound. Can you see it? But at the same time, I want to show you how this murmur evolves in a patient over span of his life. When the patient starts developing the pulmonary hypertension, the diastolic component becomes shortened. And at this point, you can have a differential diagnosis with ventricular septal defect, with second heart sound loud, because the murmur is all through the systole and there is loud second heart sound. The third picture. The bottommost picture is when you have developed Eisenmenger syndrome. When there you have got single second heart sound loud, which is obviously loud. And you also have got early diastolic murmur. You have got systolic murmur, mid-systolic murmur only. And in the last part of this slide and bottommost part, when the patient develops Eisenmenger, maybe it is not only as a result from the shunt reversal of PDA, but also for same is true for ASD, VSD, and other shunt. When the patient develops severe pulmonary hypertension, all the murmurs that they originally had is abolished. Then new set of murmur appears. The murmur due to tricuspid regurgitation, which is pan-systolic, and the murmur due to diastolic regurgitation, we know as Graham-Still murmur, which is early diastolic. There is, of course, another type of murmur that occurs in patients with Eisenmenger syndrome is mid-systolic murmur. This mid-systolic murmur is due to dilatation of the pulmonary artery. Whatever may be the causes of dilatation of the pulmonary artery, whatever may be the cause of dilatation of the aorta, will give rise you a mid-systolic murmur. At times, you are being asked about the differentials of murmur, systolic murmur along the left sternal length, and you have got so many differential diagnoses. So as regard, I have said the mid-systolic murmur, we have atrial septal defect, pulmonary stenosis, aortic stenosis, and other things. We also have not mentioned about the early systolic murmur, which can be due to sorry. Can you hear me?
Yes, sir.
I can see the slide.
Yes, sir.
Slide. I can see the slide.
So it's showing, sir.
আচ্ছা আমি একটু কন্টিনিউ করি না
স্যার আপনি বের হয়ে আবার ঢুকেন স্যার বের হয়ে আবার ঢুকেন তাহলে দেখা যাবে হ্যাঁ মনে ছেলে ছেলে বাইরে নির্দিষ্ট সরাই দেন এখনই চেষ্টা করতে জানি বাইরে ছিলাম যে
Salam, sir. Professor Abdul Salam. Salam, sir. Do you hear me?
Yeah, I can hear.
You can continue some comments regarding the congenital heart disease. You can continue.
Is it after question and answer session or just now?
Yes, you can comment before coming, Professor Meshkat, sir. Yeah.
Thank you very much. Wonderful presentation from one of my best friend, Dr. Meshkat. He is my classmate from Dhaka College, 77 BAS. And another is Dr. Shafiuddin. These two great clinical cardiologists, I'm really proud of them for his brilliant presentation, very simplified but comprehensive. If I was asked to present this vast subject in a lecture of 1 hour, probably I would not be agreed to do this, because one of the diseases is enough for 1 hour presentation.
So, Salam sir, sorry to disturb you, sir. Sir, kindly, sir, give me some moments. Mohsin sir, Meshkat sir is already in the panel list. Can you please make him host, please? I mean,
okay.
List, please.
Salam sir, you continue.
Salam sir, you can continue, sir.
Okay. So, actually, Bangladesh cardiologist field, our medical field, we are very much proud of Dr. Meshkat. He's really a great clinical teacher, not only in Bangladesh, but all over the world. Recently, he has been awarded as the best teacher award from the world platform. So I am really grateful and thanks to him because of his outstanding knowledge regarding cardiology, including congenital to adult and everywhere. So that's why pediatric cardiac courses, that is MD pediatric cardiology, is the constant or fixed moderator examiner. And every time we are facing him during exam. And important is this beautiful questions scenario he has presented. This is very useful for the students to understand. And these are, I should say, the Meshkat's googly. The students should understand or know the basics of the medical scenarios and the questions asked by Dr. Meshkat. But I think the Meshkat presentation is very much comprehensive and to understand the congenital heart disease, starting from etiology, and he has given a very much good illustrative features of genetic and as well as chromosomal diseases associated with congenital heart disease. And one thing important regarding classification, he has given the anatomical and physiological classification, which is very simplified to understand, especially for the beginner to learn about congenital heart disease. But embryology have been updated very much. Now I think there is the 14th edition of Langmans. So there are a lot of things a student should go. আমরা যখন পড়ছি তখন সেকেন্ড এডিশন ছিল বা থার্ড এডিশন হয়ে আসলো তখন so a lot of tremendous development in the embryological section, and there are a lot of new nomenclature, new things and updated. So this is a specialized chapter. I should not go into that focus area because the pediatric cardiology now has been divided into 4 sections, like neonatal pediatric cardiology itself, up to age of 10, and then growing up congenital heart disease, adult congenital heart disease. So the spectrum of disease is very vast. So so understand this subject. It is not a matter of very simple thing. So Meshkat nicely described all the things except the, including the clinical evaluation, especially remaining part of the other evaluation like X-ray, ECG, echo, and then the treatment, either intervention or surgical, when to go. So these are the things remaining. Maybe in another lecture he can complete these things. I think with these few words. And regarding the genetic disorder, one comments I want to add, that is nearly 100 genes have been identified for the defect of congenital malformation in heart. Can I hello, and some of them are prenatally diagnosed.
Can I proceed now?
Just after Salam bhai finish his comment.
Okay. Meshkat, you go on, sir.
Meshkat bhai, proceed, please.
Okay. Every murmur that abolishes, before they abolish, they show murmur in the earlier part of the system. Those are the causes for early systolic murmur. And there are also other causes for late systolic murmur. We know the prototype is mitral valve prolapse, mid systolic click with late systolic murmur. But it also happens in case of ventricular septal defect when there is septal aneurysm. And in that aneurysm causes the late systolic murmur. So we have probably covered the murmurs in congenital heart disease. The important cause for late systolic murmur is peripheral pulmonary artery stenosis and coarctation of the aorta. If you hear the murmur of the coarctation of aorta from the back, that is due to, this murmur is due to the coarctation itself, and it is going to be a late murmur. But if you hear the murmur of the coarctation from the front of the chest, parasternally, it will be mid-systolic murmur, because this murmur is not due to coarctation, but this is due to flow among the left internal mammary artery. So you have got so many differential diagnosis for left sternal aortic murmur. Next slide, please. Next slide, please. So this is a murmur with pulmonary stenosis, and as I said, similar to that of patent ductus arteriosus, when the intensity, severity increases, the length of the murmur increases, and the peak, again, peak occurs lately, and it first engulfs the aortic component and finally the pulmonary component. So in pulmonary stenosis, you may get a murmur which is similar to that of ventricular septal defect, because it has taken up the pulmonary and the aortic component. On the other hand, in pansystolic murmur of the ventricular septal defect, the murmur itself emerges the second component of the pulmonary valve. So if you get a pansystolic murmur and indistinct second heart sound, maybe you can have differential diagnosis in that way. So always apply the logic. Always try to match the finding that you have got with the probable finding of similar findings. So you should have wide range of idea about why certain disease can give so many type of murmur. In pulmonary stenosis, you can have mid-systolic murmur, you can have pansystolic murmur, literally. Next slide, please. So is with aortic stenosis. Next slide, please. Next slide, please. So as I said, these are few normal murmur. Next slide, please. Systolic and continuous. Next slide, please. So question number 6. This is my last question. Ejection click of pulmonary stenosis. Does it increase with inspiration? We know every right-sided lesion can better be elicited with during auscultation, is elicited by during respiration. But this is not true for ejection click of pulmonary stenosis, because the pulmonary valve during expiration lies in alignment with the right ventricular outflow tract. So maximum force is shared during expiration. So it is better heart during expiration. And so the ejection click of aortic stenosis, expiration, and there are also other form of click, like when, as I said, when there is dilatation of the aorta or pulmonary artery, they will give rise to some click, and there is click due to truncus arteriosus. So ejection click in pulmonary stenosis is best heard during expiration. Pulmonary component of the second heart sound, does it augment during inspiration? Answer is definitely yes. Tricuspid regurgitation in patient with Epstein anomaly. Does it augment in inspiration? The answer is no, because the right ventricle is so poor, it cannot accommodate further blood during inspiration. Systolic murmur of pulmonary artery venous fistula. Yes, this is very important, because the murmur is faint. If you have deep inspiration, you can hear the systolic murmur, and if the patient is very smartly taking the inspiration, you can also hear the diastolic component, the continuous murmur. So taking a deep inspiration and looking at the different part of the chest may be sometimes important in finding out some rare disease, rare finding. Atrial septal defect surely will not give rise. The answer is no. Next slide, please. This is for all my students whom I have not seen and whom probably I'll not be able to see. You are as green and as bright as this teacher. Next slide, please. should I continue or should I end up here?
Continue, please.
Continue.
Okay, next slide, please.
One before.
So we know the cyanosis with increased vascularity. We have seen this list, and in the X-ray we'll ought to see increased vascularity in all those cyanotic conditions. Next slide, please. The radiographer, next slide, please. They follow step by step in analyzing the congenital heart disease X-ray. Technical aspect, you all know about this. Next, please. Pulmonary vasculature is very important. Actually, lung is the mirror of the heart. We have to look at the vasculature in the lung to find out what pathological changes are occurring in the heart. We know when the left heart is failing, there is congestion, which is passive congestion. And when there is increased flow, we get prominence in the pulmonary vasculature. When there is collateral, we'll get differential vasculature with some reticular appearance. When there is no flow or less flow, there will be oligemic lung. So lung is so important. Next slide, please. 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 Also, we'll have to look at the aorta. Aorta is sometimes inconspicuous, especially in ASD and other shunt anomalies, which is the cause for not reaching blood to the aorta, will cause a small aorta. Looking at the aorta is worthy, really worthy. And in some cases, you have dilated aorta, especially in patent ductus arteriosus and in some valvular insufficiency. If it is possible, I'll show you some later on, if time allows me. Next slide, please. Especially in aorta, it is important to know whether it is right-sided or left-sided. It is important, and there is an interesting sign, 3 sign. If possible, I'll show you. Next slide, please. Next slide, please. Next slide, please.
This one.
The size of the artery, the size of the pulmonary artery is again important. We know the left pulmonary artery is more dilated in pulmonary stenosis due to post-stenotic dilation. The right pulmonary artery is more than the left in many shunt anomalies, and there are some anomalies which causes differential size in the pulmonary artery. So looking at the size of the pulmonary artery left and right is important. Next. Cardiac size and shape, you know, we can identify individual chamber. We look at the apex and we see this is left ventricular type, this is right ventricular type. If it is left ventricular type and this patient is cyanotic, we know we have only few differential diagnoses, as I said, the atresia of the tricuspid valve, Epstein anomaly, and the pulmonary atresia with ASD. As simple as that. And in other cases, the right ventricular predominance will show right ventricular type of apex. At the right border, we also have got right atrium and the right atrium. And if only right atrium is enlarged, then there is some space just at the bottom of the right border, which is occupied by the right ventricle and the inferior vena cava. That is spared. That is very interesting in some cases, like Epstein anomaly, when we have got only atrial enlargement, and that is so important to note down. Isolated right atrial enlargement. Next slide, please. Rib is important. Rib notching, deformity in the chest that give rises so many consequences in cardiovascular system. And also important to note down, the coarctation of the aorta is not the sole cause for notching. In Down syndrome, there is notching in the 11th rib, and in Down syndrome, also we have got segmented sternum. Next slide, please. Next slide, please. ECG. Next slide, please. The predominant right ventricle always show the predominance in their appearance, especially if there is volume overload, the RB is dilated and it will show incomplete RBB. Next slide, please. When the ventricles are dilated, be it left or right, it will give rise widened QRS complex. Next. It is atrial flutter rather than atrial fibrillation in the younger people is more important arrhythmia. And we know first degree heart block, which is quite common with so many congenital heart disease, including atrial septal defect. Next slide, please. Also, complete heart block is common. More talked about is corrected TGA. Left axis deviation occurs sometimes, which is an indication of common AV valve disease. Deep Q indicates the volume overload of the left ventricle. But let me remind you one thing. When the volume overload occurs due to valvular disease like aortic regurgitation and mitral regurgitation, and the volume overload due to patent ductus arteriosus or VSD will not show similar type of voltage criteria in the ECG. Prominent Q wave will be found in valvular cases in lead 5 and lead 6, because why Q waves occur in the left diastole? Because in the left diastole, the ventricle is overloaded. But if you look at ventricular septal defect, it shows more a EQ phasic pattern. And if you look at patent ductus arteriosus type, you will find a deeper S in V1 rather than a prominent Q in V5, V6. So ventricular overload, you are having a situation clinically, you have diagnosed that the patient is having ventricular overload. And if you look at the ECG, sometime you will be able to find out what could be the cause for this volume overload by looking at the ECG itself. Next slide, please. So echocardiography, I was never trained in echocardiography, not for a single day. Echocardiography, we know, is an extension of clinical examination, is a stethoscope rather, new stethoscope. So a lot to be said about this, but echocardiography is so vital. You detect the disease, you assess the severity, you assess the complication, you look at the association, you measure the hemodynamics, so you know about the pulmonary hypertension and the flow from left to right or right to flow. So many things are done in echocardiography. You need transesophageal echocardiography in few cases, especially the surgeons need, the interventional cardiologist needs it, and at the times to analyze the annulus, the annulus and the atrial septal defect with the limbs important. We have also the invasive echocardiography. In our early days, and even in nowadays also, we do some contrast echocardiography, especially in patients with ASD. ASD is a very tricky place. It's a very slippery slope for a cardiologist. So we do not do the TE all the time. We give some contrast into the right atrium, and blood come from left to right. It makes a negative shadow in the right atrium. We do contrast echocardiography. It is quite useful, especially useful when you have pulmonary arteriovenous fistula. You inject into the right side, and there will be appearance of bubble in the left side, which it should not be. Next slide, please. Next slide, please. So, echo always not give all the information that we want, especially in post-surgical cases, especially in pediatric population. They repair the tetralogy of Fallot and other things, and they want to have assessment about the right ventricular function. It is important for them. So for assessing right ventricular function at times, you may need MRI. MRI is also good for looking at the vascular pattern. So it is more important for patients with coarctation of the aorta when we are interested in looking at the collaterals before any intervention. And specifically, MRI is more important when you are planning to have some intervention. And definitely it's a better imaging modalities than the echocardiography. When you are in doubt about some finding, you may go for MRI. Next slide, please. So the hemodynamic measures are, of course, better done by echo. Next slide, please. Next slide, please. We have a summary for that. Yes, you can have a photograph of this to remember all this thing. This may be important. As I said, right ventricular volume and function is important to the pediatrician to some extent. We need to know about the collaterals and exact anatomy of ventricular septal defect or patent duct of the patent ductus arteriosus at a time. CMR is really a good good imaging modalities. Next slide, please. Atrial septal defect. Next. Ventricular septal defect. Membranous, small. Next. Patent ductus arteriosus. Next. CT is an alternative, but it by no means is superior than the MRI, but it's cheaper. You can use this, and it has got its importance in delineating the coronary arteries and often some collaterals. Next. 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 Next, please. Cardiac catheterization. We used to do a lot cardiac catheterization in congenital heart disease 30 or 35 years back in NICVD. And nowadays, there are limited indication for cardiac catheterization when we need to know about the pulmonary vascular resistance, which is so important for shunt anomalies. And in elderly patient who needs coronary angiogram, basically these are the two essential indications for cardiac catheterization in our adult practice. But in pediatric practice, they have so many complex congenital heart disease, and they really want to solve those in the cath lab. You're going to have a lecture on cardiac catheterization on congenital heart disease, so I will not be detailing. Next, please. Measuring pulmonary hypertension is now an emerging area where cardiac catheterization has got some role, because to establish pulmonary hypertension, you have to do cardiac cath. And so is with congenital pulmonary hypertension. We really need to know the exact quantity of pulmonary hypertension and the probable causes to exclude and make a diagnosis of pulmonary hypertension. Next, please. Should I proceed, or I'll show some only few slides? Should I proceed? Next slide, please.
Just a little bit. A little bit, please.
Fourth type atrial septal defect. Please proceed. Forward. Next, please. You have to be very swift about this. You remember this picture. So you can remember the superior vena cava rim, the posterior rim, the AV rim, and in short axis view, we can also see the aortic rim. Rims are important in deciding the intervention in ASD. Next, please. Next, please. Next, please. Next, please. Next. So this is the ECG pattern. You just look at the incomplete RBB, and this is slurring of the R wave in lead 2, 3 or AVF. This may be the only feature in ASD. Next, please. Next slide, please. This is the Agita. Previous one, please, previous one. Well, this patient also has got left axis deviation, indicating that this patient may have avicanal defect. Also have got first degree heart block, which is a chromosomal, which is a Mendelian disorder when we get both first degree heart block and the ASD. And also to important at the Q wave in V1. It indicates that in this patient, particular patient with ASD, do have pulmonary hypertension, and maybe this pulmonary pressure exceeds that of systemic pressure. So Q in V1 in patient with shunt anomalies indicates severe pulmonary pressure, which may even exceed systemic pressure. Next slide, please. Next slide, please. Next slide, please. This is a typical example of Agita. So আপনি বলতে দেন
স্যার একটু 2 সেকেন্ড সময় লাগে স্যার
আচ্ছা You can see the differential enlargement of the right pulmonary artery. You can see the pulmonary plethora. You can see the main pulmonary artery. And you look at the aorta, inconspicuous aorta. Always look also at the aorta. It indicates that you are dealing with a shunt, but which is probably due to atrial septal defect. Previous one, Agita, please Agita. So you have these are all X-ray of ASD. So as I said, in patient with congenital heart disease, as the disease progresses, this patient is going to have different hemodynamic profile, and this different hemodynamic profile will give different hemodynamic X-ray picture. In some cases, you will get the pulmonary hypertension, the topmost and the third from the left. You get the pruning, the very prominent vessel with oligomia in the peripheral part, and just in the middle, you are getting an shadow when there is normal lung perfusion. This is actually a post-surgical case, and in the lowermost and on the right, you may get a big right atrium and a big heart, probably right heart failure has been ensued. So try to match up with the hemodynamic that prevail with that particular patient with your X-ray. Next slide, please. Next. So these are the indication, 2010 European Society of, you can device closure. I'll not go into details. Next. And the surgery are the options. Next, please. Next, please. So transesophageal echo is quite useful in the procedure of device closure. Next, please. Next, please. Next, please. When you should not go for VSD. Okay, this one. Previous one. Please, previous one. Please, previous one. So you see the number one is perimembranous, but it was called in so many names. Conoventricular, paramembranous, and other things. And fortunately, we have a new nomenclature. We call this type number one, the perimembranous type, as type 2, muscular or trabecular as type 4, the inlet type as type 3, and the outlet type. You see so many names are there in the outlet type, and the pediatrician would have to use to confuse us in so many ways. For years together, we have struggled with all these names, and now it has become type 1. Supracrystal, subarterial, subpulmonic, infundibular, conal, all are same, and all are now being termed as type A. Okay, next slide, please. So you can see the sites. Next slide, please. Next. You have to look at the association. As I said, in this ECG, you can see the left and the lower one, left ventricular dominance is here because the patient has having moderate VSD. And at the top and the right, you can see right ventricular and left ventricular, both dominancy. Actually, the patient is evolving in a phase from left ventricular dominance to the lower right one is the Westphal phenomena, where you get equiphasic R and S wave, but you must have noted in Westphal in volume overload condition, Q is not that prominent. Next slide, please. 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 This is muscular type of VSD. You have to look at this spectral display, because many of time you may miss the ventricular septal defect. But if you rotate around your cursor by igniting the continuous wave probe, somewhere you will get this pattern. In a very difficult situation even, it gives you confirmation that you are dealing with a case of ventricular septal defect. This type of spectral defect. This is also important. You can see almost 64 or 65 pulmonary pressure, ventricular gradient from left ventricle to right ventricle. And if you add this pressure, if you deduce this pressure from brachial pressure, arm pressure, then you will get the pulmonary pressure. So it is useful in assessing pulmonary artery pressure in patients with ventricular septal defect. Next, please. Next, please. Next, please. Next, please. Muscular type, please. Next, please. So this, Agita, please. Agita. So this is type 1. Now it is called type 1. Previously subarterial, subpulmonary, whatever. It is at the 1 o'clock position. You can also see the flow. 1 o'clock position of the aortic rim. Small defect. Next. This is perimembranous, so-called. This membranous now type 2. 11 o'clock position in the aortic rim. Next. 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 So this is the angiographic picture of ventricular. Next. The indication that you can find in the next. Next. Few contraindication. Next. Patent ductus arteriosus. Next. you have to know the association ventricular septal defect and bicuspid valve. You have to understand the hemodynamics initially. Next, left ventricular oval, volume overload, and eventually pulmonary hypertension. Next. Proceed. Proceed. Please proceed. So this is the ECG. Here you can also see pressure of volume overload type of ECG. But do you find Q wave there? No. But you have prominent S wave in B1. So had this been a volume overload type of ECG of aortic regurgitation, you should have get a deep Q. And if it is mitral, if it would have been mitral regurgitation, then the S wave would have been more prominent than this one. Next, please. Next. So this is an Agita, please. For years together, I have struggled to find out the duct. Believe me, there is ductal view in the second space. You can go to the first intercostal space to find it, but it is just immediately lateral to the bifurcation. Can you see it? The right one, the left one, and just to the left of the left is the duct. But many of cases you will not be able to see this. There is an important clue to find out this. I will show it later on. Next, please. Suprasternal view, you can see the duct very, very easily from suprasternal view. This is, you can see the branches of arch of the aorta, the left pulmonary artery and the duct. Okay, next please. Next, please. Here you can see, Agita, please. Previous one, please. Here you can see the duct is not in a place where it was supposed to be. It is just medial to the left LPA, left pulmonary artery. So here you cannot see anything, neither left pulmonary artery nor you can see the duct. But the clue is to find out the aorta. I'll show you later. Here you have got descending aorta, and here you can see the. Okay, next one, please. So you have to find out the descending aorta, and from the next slide, please. From the descending aorta, then you should look a connection. Previous one. So the lowermost and the right one, you can see red color in the descending aorta, and then you will able to find out the duct connecting the left pulmonary. And also you have to look at the spectral display. From this spectral display, pressure gradient can also help you in measuring pulmonary artery pressure. If you make a minus from the systemic pressure to this gradient, then you'll get pulmonary artery pressure. Next, please. Angiographic picture for patent ductus arteriosus. This is catheter trajectory. The catheter was in the right side. From there, it has been crossed to the aorta. It is important to some extent in angiographic practice, in cath lab practice. Next, please. Next, please. Coaptation of the aorta, you have to know about the collaterals, where they are. Next, please. So this is an X-ray. Can you see figure of 3? The figure of 3 is formed by the brachial artery, the upper arm of the 3. The lower arm is post-stenotic dilatation, and the indentation is formed by the coaptation itself. You cannot see it actually. Next, please. Next slide, please. So to visualize this figure of 3, that is, now you can see figure of 3, you have to take a deep penetration of the X-ray. That is how you can actually see the left subclavian artery and the dilated descending aorta and the constricted part of the coaptation of the aorta. And you can also see the notching, which usually occurs between 4 to 8 space. Next, please. So this is notching. Next, please. Suprasternal view is quite helpful in finding out coaptation of the aorta. Believe me. Next slide, please. So you can see the branches of the aorta, And the spectral display, the wide dispersed spectral display will tell you about the presence of coaptation of the aorta. You use the spectral display a lot of time to find out all these gradient and other things. So helpful. Next slide, please. Next slide, please. Next slide, angiographic pattern. Next slide. So collateral in coaptation of the aorta. Next, please. Next, please. So you had a lot of quiz on this. This is coaptation of the aorta, but what else more? Aortic regurgitation. Next, please. Pulmonary stenosis. Next, please. We have oligamic lung and we have prominent left pulmonary artery. Next, please. And again, believe me, you will not have the same picture all the time. It will depend upon the stages, hemodynamic changes. Next, please. Next, please. Looking at the pulmonary, previous one. Looking at the right ventricular outflow tract and the pulmonary valve, pulmonary artery, and its branches is so important in patient with pulmonary valve, pulmonary stenosis. This part is very important. Short axis view, and you look at everywhere. Next slide, please. Next slide, please. Next. This is again pressure tracing. Next slide, please. Tetralogy of Fallot, the commonly encountered cyanotic heart disease. We call, when there is cyanotic heart disease, we call it tetralogy of Fallot unless otherwise proved. Next slide, please. So it is quoi en sabot. The French, the way they pronounce it. You can see almost a boot shaped. The apex of the boot is formed by the right ventricle, and the inconspicuous aorta along with the prominent pulmonary bay make this appearance. Next, please. And again, you will not have same picture all the time. You have so variation in picture with patient with tetralogy of Fallot. For example, if the patient has got very strong collateral, you may have a left ventricular type of apex. The wide angle you can see in some of the picture, and the degree of right ventricular hypertrophy is not same. So the boot sometimes the show upturn and it goes down at some stage. Next slide, please. In tetralogy of Fallot, similar to that of pulmonary stenosis, outflow tract is important. We need to know about the pulmonary valve, outflow, pulmonary trunk itself and its branches, and of course the ventricular septum. And other associated abnormality that can be with this, especially the collaterals. Next, please. Next, please. So this is an example of, we say, egg on end appearance. I'm almost at the end of my presentation, my lecture. The pedicle, the aortic root is very conspicuous because aorta and pulmonary come in the same alignment, one before and after that. It makes the pedicle so small, and the prominent right atrium and the left ventricle makes this appearance. This is typical of transposition of the blood vessel. Next, please. Our 1 minute মধ্যে শেষ করব। TGA is very relatively easy to make a diagnosis. In long axis view, if you get an aorta have a bifurcation, it means you're dealing with TGA, and at the same time another artery parallel to left ventricle and right ventricle have two parallel exit. Next, please. In 1 minute, I'm going to finish. Aorta is in front of pulmonary artery. Two circle, all in short axis will make you the suspicion. Next, please. Next, please. Next, please. Next. So next, this is figure of 8. Previous one, figure of 8. The upper portion of the figure of 8 is formed by the superior vena cava and the transverse vein, where all the pulmonary veins unite together to make a vein, which gives this prominence. The famous figure of 8. Next. Next. Amar hoye geche, আমি শেষ করতেছি। Aortic stenosis. Next. So knowledge comes from learning. Knowledge is what? When we say we have learned so many things. And wisdom is what, when you say, this much I knew. Actually, this much I knew about the congenital heart disease, but I really knew this much. I'm not a wise person. We have wise Salam sir, and I don't know whether Nazul sir is there. He has been my teacher for last 35 years. He has been so excellent in teaching me, and still he's teaching me all the aspects of cardiology. Hats off for him. Hats off for Professor Jalal and all my respected teachers. Thank you very much for giving me the opportunity. Thank you. Next slide, please.
Thank you, sir. Thank you, sir. Nicely presented. A big chapter within a short time, only 90 minutes. Big chapter, sir. It is possible to finish within 90 minutes, sir. Due to some technical difficulties, some rhythm, maybe sometimes is it not harmonic, but it is excellent deliberation, sir. Thank you, sir.
Thank you.
Thank you, sir. Professor Razia Sultana Mahmood, madam, do you hear me?
Yes, I hear you.
Yeah, madam.
I must thank Dr. Meshkat for his excellent presentation. Actually, I went through my academic teaching. When I was a student, I went through the congenital heart disease chapter, but not so much in detail. It was very nice for me to hear the whole lecture, and I must give you a real clap. I must say, salute you for your excellent presentation. And especially you went through such a big chapter in such a short time, explaining most of the things in detail. It was very well done. Thank you.
Thank you, ma'am. Ma'am had been my teacher for a long time, and I learned all the echocardiography from her. I'm so grateful to you, ma'am.
Thank you. You're welcome.
Thank you, sir. Wadud, sir. Professor Wadud, sir. Sir, do you hear me, sir?
Yeah. I'm really happy that we have invited Meshkat Bhai to give this lecture.
Mohsin.
Because as Meshkat Bhai was saying, we have been so much technology dependent, and the glamour of technology has sometimes blinded us. The clinical cardiology, as I am a great fan of that, is nowadays very much neglected. But if you have a look at the patient, and that gives you some clue what you can anticipate from your echo findings, your chest X-ray finding, and the ancillary basic investigation like an ECG or an X-ray can really help you from the clinical information as well to decide what you are seeing in echo, what does it actually mean, or are you missing a part of the puzzle? Meshkat Bhai has beautifully shown there. And he has particularly put emphasis on particular components of the clinical examination, which we do not often pay attention to. We often ask the patient, look at this cyanotic child, and just having a look, can you say this is an Eisenmenger or a Prof? This clinical acumen. Look at the precordium. If it's moving, then it's Eisenmenger. If it's silent, then it's most likely Prof or some varieties of Prof-like pathology. These simple clues really help you in giving the right diagnosis. Meshkat Bhai, thank you again and congratulations.
Thank you, sir. Dr. Shariful Islam Raton, do you hear me? Dr. Shariful Islam?
Please unmute.
Happy to unmute and ask a question, please.
Dr. Raton.
Please unmute yourself. I think you are on duty. Please ask a question. Unmute yourself.
Doctor, unmute yourself. Unmute and then ask the question.
Probably he is not here, sir. Go to the next question.
We can hear.
Yeah, Dr. Lipi, Dr. Lipi Damnath, do you hear me? Dr. Lipi, do you hear me?
Lipi, unmute and ask your question.
Okay.
We cannot hear you. Detach the headphone and then ask.
Okay. Then open your earphone and ask a question. Okay, earphone. Okay. Now ask a question. Okay.
Sir, can you hear me?
Yes, yes. You ask a question loudly. Okay.
Sir, actually, I didn't put any question. Thank you, Meshkat sir, for your nice delivery because it's the
Lippy, you cannot hear you. Talk to the device directly.
Sir, do you hear me now?
Now,
Yes,
now
yes.
we can hear.
Yes.
Okay, sir. Actually, I didn't put any questions, sir. This is a very nice lecture, and I enjoyed. And because the sir includes every clinical aspects from fashion.
Shuriful Islam Ratan Bhai is here. Ratan Bhai, are you there?
Yes, yes.
Yes, ask your
I
question.
have one question. Very excellent lecture. Sir, I have already written the question. What do you mean by right dominant or left dominant?
Meshkat sir.
Sir,
Yes, dominant when the right ventricle is dominant.
sir, you tell in your lecture whether it is right dominant or left dominant.
When the right
What does it mean?
when the right ventricle prominent and it takes all the pressure and
Prominent in
part,
function or hypertrophy? Sir, prominent in function or in or hypertrophy?
prominent in function, but I have got little confusion when we have transposition of the great vessel. Then what we mean by dominance of the right and the left? That is the confusing area. Other than that, right dominant means functionally dominance of the right ventricle, and of course this function is a result mooted from the structural changes.
Sir, it is related with the ejection fraction of the right ventricle or others?
No, not necessarily, because the right ventricle may fail. The dominant ventricle may fail, so it is not the function all the time, but maybe initially. But the whole circuit and the whole hemodynamics, when it's predominantly through the right ventricle, it is called right dominant.
Can I, Meshkat, can I add one thing?
Of course, sure. You're the right person.
No, actually, the terminology where we use this right dominant, left dominant is in the diagnosis of complex congenital, particularly in univentricular or single ventricular settings. The which of the ventricle is dominating or functionally giving the systemic and pulmonary circulation. It may be either right ventricular or left ventricular. In that setting, then great vessel is also differ. It may be DORV, DOLV, like that. So to understand this ventricular dominant, we usually prefers to indicate the univentricular heart.
Thank you, sir. Dr. Sami Islam, do you hear me?
Yes, Assalamualaikum, sir.
Okay.
Sir, thank you for the nice lecture, sir. And I have a small query, sir. Sir, in case of when we are asked to present the case, sir, in short case or long case, sir, if the patient is ASD, sir, we are usually asked that post-device closure or post-surgical closure, sir, will the bundle branch block disappear, sir? And how long will it take if it disappears, sir? Thank you, sir.
I don't answer precisely, but it does not disappear. Common sense. It actually do not disappear. We do not see it to disappear, because initially it is thought that the dilatation of the right ventricle actually increases the whole length of conduction. That is what the right bundle branch of, and once the intervention is done, reduction of the right ventricle will reduce the conduction. But the case is not always true. It remains there probably, but I'm not really sure about the answer.
Can I add?
Salam, sir. Salam, sir.
Yeah. Actually, in case of atrial septal defect, whether you close by device or by surgery, actually from SA node to AV node, the conducting tissue will mostly run through the walls, not through the entire atrial septum. So after closing or after pressing over this, usually some kind of transient supraventricular tachycardia or some atrial tachycardia may happen, but it gradually settle down until you touch the AV node, lower down. So in some cases of inferior rim deficiency, in that case there might be some problem in long term or in intermediate term or short term. So after device closure or closure by surgery, a regular ECG monitoring or clinical symptomatology should be asked to the patient.
Dr. Nilüfer Fatima, Dr. Nilüfer, do you hear me?
Yes, sir. Thank you, sir.
Yeah.
It is a great pleasure for me to hear from my first mentor in cardiology, Professor Chowdhury Meshkat Ahmed, sir. He has been awarded Best Teacher in World Forum. I am so proud of my sir. And he has shown beautifully in his lecture on all aspects of congenital heart disease. I use air bubble contrast in my outpatient, which sir has been shown to me in all time. And whenever I am confused with ASD or maybe septal aneurysm, where we don't see the ASD, we cannot locate, then I use air bubble contrast, which is very useful tool in outpatient echocardiography.
Do you have any question? Any question for the faculties or anything in your mind?
No, sir. No, sir. Thank you, sir.
Thank you. Dr. Sudisha, do you hear me?
Yes, sir. Assalamu alaikum, sir. And thank you very much for giving me the floor. I'll be taking 40 seconds extra, sir, and I beg pardon for that. Professor Meshkat Ahmed Chowdhury, sir, he's a very humble person I have ever seen. And he is known as a legend in the field of echocardiography, both home and abroad. But probably many among us don't know that he is an exceptionally good clinician. And for me, this is the first PowerPoint presentation of sir. I must say here that I have never seen him using PowerPoint during his lecture. And despite that, his lectures are always very organized, systematic, and loaded with information. He has beautifully covered all the clinical aspects in the lecture. Thank you very much, sir, for an exceptionally brilliant presentation of today. Today's question, I have one confusion. That is, all these days I had known that the only cause of wide fixed splitting of the second heart sound is ASD. But today you have added two new things. One is the pulmonary stenosis with right heart failure and MR with right heart failure. But as I know that these are the causes of wide splitting of...
Also TAPVD.
Yes, sir. But as I know, sir, these can cause wide splitting of the second heart sound. But how are they causing fixed splitting? Fixed splitting, how, sir? This is the one question. Second question I have, sir, that it is said that even if a child has a very large VSD, they don't manifest with chronic heart failure or congestive heart failure until they attain the age of about 8 weeks. And why is it, sir? What will be the changes in the radiology and ECG in a patient of VSD, large VSD, before and after development of Eisenmenger syndrome? These are the three questions.
Sir.
Answer. When the RV cannot expand anymore, then any variation, any load in that will not change the distance between aortic and pulmonary valve closure. That is what happens when right ventricular failure occurs in patients with pulmonary stenosis and mitral regurgitation. As simple as that. But wide splitting also occurs in case of total pulmonary venous and abnormality. When during the inspiration or during expiration, it has got its maximum load, maximum capacity. The RV is already has taken its maximum capacity so that it cannot expand more during inspiration. A failing heart really cannot take extra load during inspiration. That is the simple explanation to that. The second answer to the last question, when in ventricular septal defect, when we have left ventricular volume overload, we'll get the pictures of left ventricular volume overload. Eventually, when pulmonary hypertension will develop, there will be features of biventricular failure known as Kasparov phenomena. And finally, when there is Eisenmenger syndrome, we'll get the features of predominantly right ventricular hypertrophy in ECG. As simple as that. The reason why large VSD do not get the failure in a very early in their life is at that time the pulmonary vasculature was not that dilated to conduct all the burden of blood that is conveyed to the left atrium. Probably this can be the reason, but Salam is there. He may add something.
Can I add something?
Yes, sir.
Remember that in fetal circulation is right-sided dependent. The pulmonary resistance is very high. The blood all shifted to the left. Now, after birth, the lung started expanding, but the resistance is still even a little bit high. With the child grow, the pulmonary resistance falls further. Now, in case of VSD, because of the extra flow in there, the resistance doesn't fall that much. Sometimes that's why you do not get that earlier. But in case of PDA, large PDA, the child comes much earlier because of the extra flow to the lungs and that floods the lung. And pulmonary hypertension much earlier. Salam bhai.
Yeah. Thank you very much. I think you have nicely described. What I understand that is the recognition by clinically the second heart sound splitting or reverse splitting very difficult for the beginner. Number one. Number two is when there is any volume overload or pressure overload, there is increased flow through the pulmonary valve. The valve cannot close earlier as with that of the aortic valve, lunar valve. So there will be splitting or fixed splitting and reverse splitting in case of aortic stenosis. These are the simple things I want to comment. And thank you.
Sir, পরীক্ষা স্যার আমরা যদি ফিক্সড ওয়াইড ফিক্সড স্প্লিটিং এর কজ হিসাবে যারা স্যার চারটা বলি স্যার কোনো প্রবলেমে পড়বো কিনা স্যার এটা একটু ক্লিয়ার করে
প্রবলেম হবে এটা পরীক্ষা বলা যাবে না don't
the thing is only two lesion actually produces the fixed lesion very clearly. One is ASD, second is TPPD, which is actually a sort of ASD.
Yes, sir. Yeah. Only two, ASD and TPPD.
Only two. And that two, the last two, that comes with heart failure, RV failure, because the RV cannot act on changes of the loading condition. But that seems a little bit controversial, but because according to the state of the RV failure, that situation may change. So you can safely say the first two, SD and TPPD, you can say safely. But last two, you should remember that Meshkat bhai has explained very nicely. Very nicely.
Thank you, sir.
Thank you.
One thing I want to add, Wadud bhai, that when there is fetal pulmonary stenosis and there is the second heart sound will be attenuated. In that case, you may miss this splitting.
Actually, splitting, we can actually hear it.
So, important two issue, that is the ASD fixed wide splitting and reverse splitting aortic stenosis. So these are the two important things I think we should not miss.
The other important is why you can have the physiological splitting and how you can differentiate it from the pathological splitting. Especially the physiological splitting changes with respiratory phases, but the pathological splitting do not, as Meshkat bhai has shown it.
আমি বলবো তো actually when there is pulmonary stenosis in mild or moderate degree, you may have normal pulmonary component of the outside. You may have. And at the same time, some unwanted situation can provoke a heart failure in that patient. For example, some volume overload condition on some, for some reason. If in that stage that patient develop right heart failure, you may get the picture of fixed end stage. And even in the end stage, you are supposed to get a long murmur, isn't it? But when you have the heart failure, the long murmur of pulmonary stenosis become reduced one. So for academic interest, you should know the wide world of congenital heart disease. You should go into the depth of everything to know what can happen, what is possible, and what is probable.
I should draw attention to another fact. The findings, clinical findings in a child and clinical findings in an adult are different. The heart sounds and everything, you can actually hear much better in a child. you can differentiate them much better in a child, particularly if the heart rate is not that high. But in case of adult, that's sometimes a little bit difficult.
Thank you, sir. Khalid Mohsin, sir, you have a lot of experience on the examination hall as a registrar. Few comments, sir, for the exam, for the big chapter, for the exam.
Yes. Yeah.
Yes.
Actually, it's a superhuman effort, Meshkat, to cover so many single lecture. Actually, from the examination purpose, we should concentrate on those entities in those the child survives up to the mid-childhood or early adulthood. We expect to get those patients, and the taking history from the mother is also very important. Starting from the conception, antenatal period, paternal consanguinity, all the things Professor elaborated. I need to clarify two things in advice lecture, that the difference between a to and fro murmur and a continuous murmur. In a to and fro murmur, the blood flow is in one direction systole and in another direction systole. And in continuous murmur, in both systole and diastole, blood flows towards the same direction. This is one thing. And regarding the accentuation of the ejection click, we simplify this thing that when there is the end diastolic volume is increased, the semiannular valve floats up, and this attenuates the ejection click. And when there is volume is reduced in the ventricles, end diastolic volume, the ejection click is more prominent. Just these two things to remember. And I like to give a compliment to Meshkat Bhai because of the three things. Number one, he's a thinking cardiologist, not only, and he's a very outspoken person. He's not scared of expressing his feelings and emotions, and he's not wasting his time in private patient consultation, unlike most of us. For these three reasons, I like to express my gratitude and appreciation for him. And he is my course mate in the MD cardiology course. So I have a very special place in my heart for him. So thank you so much.
Thank you. Thank you, sir. Thank you, Rabiul Shakar Rana.
Yes, sir. Thank you. Thank you for giving me the opportunity. I was from the very beginning following the lecture of Meshkat sir lecture. I know that sir is very good in delivering the theoretical and also the practical aspect of echocardiography. What I want to just criticize one thing is that this is a very important chapter and very big chapter. So, sir, one request of from me is that you may divide the lecture in two lectures so that we can enjoy it, we can learn it more properly. Because sometimes doing a HD and differentiating the VHD, different type of VHD, is really challenging. Even the expert cardiologists, they don't know even the types of VHD they are doing by echocardiography. So I think that if we give another opportunity to Meshkat sir to deal with some smaller thing like HD and VHD, that's all. Then we can learn more and it will be more fruitful to us, because there is a huge chapter. We just see the heading of some congenital anomalies. Thank you, sir. Thank you very much.
It is a class of overview of congenital heart disease. How we approach a patient of congenital heart disease, not the class. It is like of examination and the congenital heart disease. So it is the overview of the congenital heart disease. Next time
my request is to divide in different segments so that we can more palatable. That.
Okay. Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, Rana.
Dr. Sawari Ranjan Rajgopal from Malaysia. A comment?
Yes, thank you all for this, giving me an opportunity also to listen to this. The talk just now was very comprehensive, and I really appreciate this speaker because he really took a lot of pain to prepare the slides. I can understand that. It was so extensive. I must thank him. I only got 2 or 3 basic questions which I like to ask. Number one is, in primary care, can ultrasound be used to detect early cardiac anomalies? That's number one. Number two, how badly was this people with congenital heart diseases affected during this COVID-19 infection? How badly were they affected? And yeah, these are the two things I like to know about. Very basic. Thank you.
It is from the famous fiction of Edith Segal, Doctors in Love, where they have shown the main character heroine. He was in Ethiopia in a desert area when he used the ultrasound, an ancient ultrasound, to make a diagnosis of pericarditis. So yes, of course, ultrasound will be of help when you do not have the echocardiography and other modern medication. Probably, if I answer the question, if I understand the question, whether ultrasound can be used in abnormalities, this should be my answer. But rest of the answer can be given by Salam, the PPT.
Can I add something?
Yes.
That is POCUS, that is the point of care ultrasound is another mode of that is the portable echo machine are available, particularly in emergency care center, just for the functional diagnosis and particularly for the management. It is to mention one important thing, particularly if a new net presented to you, the 4 common mistakes usually done by ultrasonographer or cardiologist doing echo. That is TGA, intact septum, pulmonary atresia, or that is the drug-dependent circulation, either pulmonary atresia or hypoplastic left heart syndrome and obstructive PPVC. And these are the common scenarios. These patients usually, if we do the misdiagnosis or mistake, this is very much life-threatening. So this point of care ultrasound, that is cardiovascular ultrasound, is an important issue which have been added in the armamentarium of this pediatric cardiac care patient. Can I add 1 or 2 minutes?
Yes, sir.
That is, I want to congratulate and thanks, and I have to pay my compliments.
You had also question, Salam, you had question about COVID and the congenital heart disease.
COVID? Yeah. COVID. I'll answer. What is the question?
My question was how bad was the patient's congenital heart disease affected during COVID-19? And I also got one more question. Does traditional medication cause any kind of congenital anomalies? Children?
Actually, you see, COVID-19 is a multi-system disorder affecting all age group. Although due to the presence of innate immunity in case of children population, the frequency or prevalence of the disease is less, and as well as morbidity, mortality is also less. But they are not sparing in case of certain group of pediatric patients, those who are immunocompromised, having some malignancy or some malnutrition and other condition. And recently, Kawasaki-like syndrome has been appeared after this COVID positive cases. And this patient we need to follow for long-term coronary abnormality, like that of the Kawasaki disease. And management is like that of the Kawasaki. We have to give IVIG therapy as well as dexamethasone or prednisolone we can add. And regarding the adolescent population, like the growing children, is like that of the adult cases. So they may develop a multi-system disorder like severe pneumonia or cardiovascular problem like heart failure, pericardial effusion, endomyocardial edema, and these are all arrhythmia. Even cardiogenic shock, multi-organ dysfunction can develop in case of pediatric population resulting from this COVID-19 infection. And these are all few things I can add.
There's a last question from Nazim Shoikos, sir. Nazim Shoikos, last question from Nazim Shoikos.
Yeah.
Hello.
Here?
Yes, sir. Assalamu alaikum. So, can you hear me?
Yes.
Okay. Thank you for having us on this excellent session, sir. I have 2 questions. Why hypoxic spell is rare after the age of 2 years? And another question is how platypnea orthodeoxia syndrome is developed in pattern foramen ovale patient? These are my two questions to Sir Meshkat sir.
Meshkat sir,
yes, platypnea or orthodoxia that occurs. The basic reason for developing of this syndrome is actually peripheral, the vascular resistance in the pulmonary circulation, which causes the stiffened lung, and we become more stiff while you stand from sitting. Probably Salam will be able to say more. And as regard why cyanosis appears late in patients with tetralogy of Fallot it is the course of the disease. In initial stage, the duct is open, and the left ventricle, the right ventricular infundibulum is not over responsive. I have to quote Salam.
Thank you very much. There are 2 or 3 mechanisms has been explained. None of them is confirmatory and none of them is unique. That is, the infundibular spasm is related with the emotional instability, and sympathomimetic increased sympathomimetic. These are precipitating factors. And there is a increased infundibular spasm and decreased flow to the lungs. That is, the lung flow of blood is decreased, so hypoxia results into that's due to the and compensatory mechanism usually initiated by the respiratory center in the brain, which results in hyperapnea also. So deep shying respiration, as well as older children, increase older children, that's because this is there is increased flow by squatting posture. They usually assume this, but this mechanism is depending upon the level of obstruction, either infundibular or valvular or supravalvular or combination. And most of the case, infundibular and valvular component is in 75% of the case of tetralogy of Fallot. So these baby may develop severe cyanotic spell even after birth if there is severe infundibular stenosis or pulmonary hypoxia, and in that case you may need to go for RBOT stenting or a BT shunt, or if there is any compensatory PDA flow, you should go for PDA stenting to increase the or augment the flow. In that case, most of the case, if we go for when the medical management fails, then we go for intervention or surgery. But mechanism, there are 2 or 3 theories. So or none of them is unique for all patients.
Thank you, sir. Yes, sir. Sir, Professor Jalal, sir. Professor Jalaluddin, sir. Do you hear me, sir?
Mohsin.
Professor Jalaluddin, sir.
Mohsin.
Yes, sir. Yes, sir. After Jalaluddin, sir, comment, sir. After Jalaluddin, sir, you can comment.
Yes.
After Jalal, sir. Jalal, sir.
Are you hearing me?
Yes, sir.
Are you hearing?
Yes, sir.
Yes, sir. I thank. Are you hearing me?
Yes, sir.
Yes, sir.
Yes, sir. I thank my brilliant student, Professor Meshkat Ahmed. He had delivered his lecture, the whole of the congenital heart disease, in less than 2 hours time. He has given much more stress to the clinical examination and clinical findings, plus extra findings in the diagnosis of. Are you hearing me? Are you
Yes,
hearing
sir.
me?
Yes, sir.
Yes, sir. Yes. Now, previously, when I started cardiac catheterization in NICVD, I did in congenital heart disease, not in coronary heart disease. At that time, cardiac catheterization was the main way of diagnosing the congenital heart disease, because the echocardiography at that time was not much developed. Only the 2D echocardiogram, black and white, was established at that time. Later on, the color Doppler and the echocardiography have replaced the diagnosis of common congenital heart disease. But still, it requires the cardiac catheterization when you go for interventional correction, catheter correction, as well as the surgical correction. So, Dr. Meshkat has described the clinical examination and especially the nature of the murmurs in different congenital heart disease, which is very much essential and for learning for the students. Thank you, Professor Meshkat Ahmed. Once again, thank you very much.
Thank you, sir. Thank you. Assalamualaikum, sir. Salam, sir. Salam, sir.
I should not talk after sir. I beg pardon of me. Actually, sir. I want to pay my respect and gratitude to Professor Jalaluddin sir, because he is the man, pioneer, who started pediatric cardiology program in NICVT in Bangladesh first. He recruited me I was a simple pediatrician after passing FCPS and MD. I have been recruited by him. So he has a lot of interest on congenital heart disease. Also, Professor Nazrul sir, these two fellows, my teacher, respected teacher, they really fought against many of odds to establish the pediatric cardiology department in NICVT. So I salute to him. And I also pay compliments to Professor Razia Sultana, madam. He also contributed to this development. As well as I have to compliment Dr. Sarwar Raja Gopal from Malaysia for his outstanding participation. And last but not the least, my friend Dr. Meshkat, what a efforts he have given, what a energy he have given, what a patience he have given. Salute to you, Dr. Meshkat, my friend. Yeah, excellent presentation. Sorry, I couldn't understand. I was thinking after 1 year it is finished, but you have illustrated many things in a very short span of time. Thank you very much. Thank you, Professor Khalid Mohsin sir. I learned many things during my early part of life. I worked with him in the unit of Professor Jalaluddin Nazrul sir. So, a lot of thanks to Professor Wadud for organizing such a brilliant session for congenital heart disease, particularly for the beginners. Thank you, Arif. Thank you, Shajol, Arif, and thank you.
Sorry, we have to wind up, please. I think we better wind up. It's already too long a session.
Thank you,
Dr. Mohsin.
Thank you, sir.
Dr. Mohsin, are you there? I think his network is not working. All right.
Mohsin sir has left. I think he will be coming.
Yeah.
Okay.
Right, now we are going to conclude. Shajol, I think we better finish, please. It's almost 5:45. Is too long the session. Meshkat bhai, it was beautiful, as I have already said, and the students will be greatly benefited because you have done an exemplary job, and all these things have been put down in writing. So when they go through the lecture again and again, as it will be available in YouTube, they can learn, as I always say, at their own pace, in their own leisure time, whenever they wish to go through it, and find out the pearls that has been presented by Professor Chowdhury Meshkat. We had a great session, great participation from our panelists, great audience. I hope we will be continuing in this vein in future as well. This has been a long afternoon. I think we should be winding up now. Dr. Professor Mohsin, you please wind up.
Yes, sir. Do you hear me, sir?
Yeah, wind up, please.
Yes, sir.
Thank you, Professor Meshkat Ahmed, sir. We give a lot of pain to prepare their big chapter, sir. I think it is, I have a question for Professor Wadud, sir. Please give advice for the students how to read this chapter for the long case or written exam, sir. Wadud, sir. It is a big chapter. For the
I will say three things.
Yeah.
always we ask the question about the common things. Make common things the answer very appropriate. Second, prepare for the common conditions that are presented as cases in long case or short case. 3. There are questions that are mainly written, they are usually asked in the written question. This is a separate thing. The classification, otherwise approach, and also the short notes, like how are you going, what is the mechanism, how are you going to manage short spell, like that. You differentiate the 3 parts and go through the books. Take the help of the lecture that has been given to you, a gem of a lecture that has been given by Professor Chowdhury Meshkat Ahmed, and recapitulate. Go and forth, and do not try to go through the whole lecture at a time. Go to a part. What he has said in the embryology part, what he has said in the clinical part, what he has in the later part said in the different common disease part, ASD, VSD, PDA, TGA. So they're just 4. The most important 4. He has said that. He has described those, the key points. He has mentioned that. Go through that and make your own peace with the whole subject. You will pass. You will learn something, and you will be successful.
Thank you, sir. Thank you, sir. Thank you to the Meshkat sir again, sir. Thank you, sir. Thank you, Professor Salam. He also nice contribution to these classes. Also, our Malaysian faculty. Thanks, Mohsin sir. For their effort for last 3 months. Our next class on Sunday at 3 o'clock is the pericardial disease by the Professor Shahabuddin sir. Is the Professor of Cardiology. Just save and take care, everybody. Assalamu alaikum. Goodbye. Allah Hafiz.
Assalamu alaikum. Thank you, sir.
Thank you.
Allah sir, assalamu alaikum, sir. Meshkat bhai, thank you.
Assalamu alaikum, sir. তুমি আমার